welcome to Health Talk. I'm Kimberly, and today we're going to be interviewing Dr. Gloria Wu, ophthalmologist in San Jose, and we're going to be discussing eye emergencies and what Dr. Wu comes across when she enters a hospital emergency room. Dr. Wu, what are some eye emergencies?
I have frequently been called for various things. The most common one is I stuck something in my eye. Okay? So here's the eye. So to us, this is like gigantic. To most people, it's only, about an inch big. So what happens is you can stick something in the eye right here.
Okay.
And then some people get a sewing needle in the eye.
Oh,
the sewing machine breaks off the needle and goes in the eye. That's kind of bad. High velocity. So sometimes we need to go to the operating room for that. I'm a retina surgeon, so I get called for that. I've been called about that. Simple things is, a piece of dirt in the eye, I'm grinding, and I get a piece of iron in my eye. That's simple. Not so good is soccer ball goes into my eye, tennis ball.
Yeah.
Tennis ball, squash ball, golf ball are the worst because it fits into the eye socket and you could really blow out your eye. So what happens when we look, what we get called about that, sometimes we're called at 2 o'clock in the morning, midnight, and I've been losing a lot of sleep recently because I've certainly been on call a lot. So what happens is that if an impact, here's the ball that's coming in or some object that's coming in. So it's going to hit the eye and the eye goes in and then out. Okay. So there's a bounce effect because there's almost a plunger effect. So here you have the eye, the inside lining of the eye is the retina. In the middle is the vitreous. So if you have a high impact ball, like a tennis ball,
Right.
even a soccer ball, it's going to go in, and you think because the eye is soft, it's going to give. So it's going to go back into the bony socket and then come back out again. That action is like a plunger. So all these little structures, all of which are 250 microns, 300 microns. So one hair is 50 microns. So each structure is the diameter of 6 hairs.
Very
so
small.
That's heavy duty. The cornea is pretty durable because this is about 600 microns. So that's about a lot of hairs. So, but still, it doesn't like, each cell layer is more delicate. So you're going to push against this, and there's going to be damage on the front part, into the iris part, which has blood vessels, and it can cause bleeding. So what happens, you get hit first here, the impact here, the cornea, so the cornea may get hurt, you get an abrasion, and then the plunging action, the in and out action of that force will cause these blood vessels to leak here, and you get blood right here in the anterior chamber where my finger is between the cornea and the iris. You get a hyphema, so you get blood right here. So your eyes, instead of being blue or brown, is covered in red blood, so you can't see. Then your lens gets shaken. So the little strings that hold the lens in place are a few microns also. So they're waving, holding this lens. This lens can fall into the eye, like fall into your retina, or partially fall into your retina. This is no good. We again go to the operating room. Then, if that doesn't happen, your lens is okay. Then the blood, the vitreous here, the gel that's in here, can be filled with blood because it rubs on all these blood vessels, causes bleeding. Then there's a retinal hole or retinal detachment. And then, so we're called into the operating room for those reasons. And that's usually an emergency, 2 o'clock in the morning, midnight, 3 o'clock, 4 o'clock, 7:30 in the morning, depending on when the person ate last, because we need 6 hours of no food, 6 to 8 hours of no food before we operate. Okay. So what happens is there's also gunshot injuries to the face, and then it may graze the eye, break the socket, and then the eye is kind of hanging out there exposed. Those are called ruptured globes, where this is all broken up, and so the innards of the eye is spilling out.
Oh,
That's
no.
not so good. Again, to the operating room, but those are usual team of surgeons. You'll have the plastic surgeons, the neurosurgeons, the ear, nose, and throat surgeons, and the ophthalmologist all hanging out at the same time.
Saving this eye.
Yeah, we have a party in the operating room in the middle of the night, but we're awake. So usually those have less ability to regain sight, but we save the eye. There's some sight left, but sometimes we're very fortunate in this day and age, people can have good vision. So it depends on the extent of the injury. The other things that we're called about in the emergency room is pain, severe pain, nausea, worst headache of their life, and that's angle closure glaucoma. And what happens is that we know that glaucoma happens to everybody. Grandma has it, grandpa has it, and we think, oh, they just take drops forever and it's okay. However, angle closure is a second type of glaucoma where it is you have about 6 hours to fix them, to get them eye drops, to do the laser. So what happens at angle closure is here's the lens and here's the blue part of the eye. So what happens is that the blue part of the eye and the cornea, that space becomes narrow. So again, let's use the analogy of pretend your eye is a room and you're standing in the middle of the eye.
Okay.
So if you're standing and you're lying on the ground, the eye is positioned like this.
Up. Okay.
Yeah, you're standing upright and the ceiling is the cornea. And so imagine the roof is the cornea and the ceiling is where the blue part of the eye is.
Okay.
So imagine the ceiling, instead of being in a nice place on the first floor and you have a 2-story house, the ceiling of your first story pushes up against the roof. It just flies up against the roof like magic. And that's angle closure because you no longer have the space between the first floor and the roof.
How often do you see angle closure glaucoma?
It is not so common because people go see their optometrist, especially in California, and there is good eye care, and it's caught earlier because people can be seen in the doctor's office and it could be noted that their angle is already narrow, so that your house, your ceiling is already vaulting upward close to the roof. So people will think, oh, you're abnormal, go see your ophthalmologist. And then at the office, we would make a laser opening from here, from the iris to the back, so that there would be another pathway for fluid to travel between the first floor ceiling and the roof. So the angle is where the first floor ceiling is and the roof. So that is the angle. So that closes. Between the first floor ceiling and the roof are pipes that go around the ceiling that drain the eye of the pressure. So what happens in angle closure, when that happens, probably the patient put himself at risk by going to a dark movie theater, because that's when the eye, the muscle changes, the pupil opens up, and that ceiling already is becoming, which was prone to this, gets closer to the roof. So the person was in a dark movie theater, comes in and out, goes to a lit place, and if the person is maybe 40 years old, this muscle, the ceiling, the first floor ceiling doesn't work normally and gets stuck. And we don't know why it does, but people are predisposed to it. If family members have had this, it can run in families.
Hereditary.
And it also comes with certain medications. Certain medications if you're already prone to this.
Wow. So when you go into the emergency room and someone says, hey, Dr. Wu, I got punched in the eye, they beat me up, I lost my vision, how do you go about to treat this condition?
The first thing we do is take their vision, because sometimes they lost their vision, but it's temporary. They think they lost because they're used to perfect vision, and they may have just lost their vision to 20/40, which we don't think is such a big deal. So that means we already know by taking the vision how serious it is. That's the first step. Then we look at them at a slit lamp in the emergency room. Some emergency rooms in rural areas don't have a slit lamp. Then you have to rely on a pen light, a little flashlight we carry, and we see if all the structures look the same. So using the house analogy, you want to make sure the first floor ceiling is where it is, the roof is intact, and that there's nothing funny looking about that. Then we take a pressure of the eye to make sure they don't have glaucoma, that there's something that we're missing. And again, in rural situations where they don't have that, we have it in our kit that we bring to the emergency room. And then we look to see, we dilate them to make sure that the retina is okay. Sometimes you get punched in the eye, it's not so bad. You have something called commotio retina, which is a Latin term for what it means that you get pinched in the eye and the retina is just swollen.
Oh,
But
okay.
you'll recover. The retina, instead of being nice and orange color, filled with normal blood vessels, it turns white and is swollen. It's temporary, but it'll work. We know it'll come back. We give them drops and it'll go away. Sometimes it's not so good if you're punched in the eye. Usually, most commonly, is they get a hyphema, which is filled with blood here, and they can't see. Then most of emergency rooms do not have ultrasound capability, so we could see if there's a retinal detachment. So we usually try to figure out in other ways if there's a retinal detachment. We sometimes can put the light here and see if they can see it here, and put the light here and they see it here. So you can shine light, it's called directionality, to see, transilluminate, to see if they can see different parts. If we think there's a retinal detachment, sometimes we can bring our equipment from our office, because there are portable ultrasound, to see if there's a retinal detachment. The other emergencies that is kind of funny but happens, people have stuck super glue in their eye they thought was an eye drop. That is very painful. What happens is they usually put super glue, they glue their eyelashes, their lid to the cornea.
Wow.
So
okay.
it is extremely painful. What happens is the cornea is glued to your inside lining of your eyelid. You can heal. They're going to separate it out. They peel the first layer of the cornea. It's extremely painful. It takes about a week to recover, but you will get your vision back. The other thing is, some people put eardrops into their eye.
Okay.
And that's just the wrong pH, and they just hurt their cornea. They will recover.
Good.
Women commonly stick a mascara wand in their eye. I see this once a year. They're driving in the passenger seat. Their car stops suddenly. They stab themselves with a mascara wand.
Yeah.
This is common. What else? Some ladies like to separate their mascara using a safety pin.
Yeah, I've heard about that. Yeah.
Okay, they stab themselves in the eye with a safety pin. Not so good.
Not so good.
No. If it's mild, they do not have to have surgery. If it's
so it can require surgery if it's severe.
If they stab themselves all the way in.
Oh, okay.
Okay.
Wow.
Because it could be infection. It could be not so good. What other common ones? People spray themselves with hairspray in their eye, perfume in the eye. That's just painful. That's temporary. What else do I get called about? I get called about babies being dropped onto the floor, and the baby slipped. It's usually new mothers, or the babysitter dropped the baby, and they dropped the baby face down, really bad. Okay, usually to the operating room.
Wow. So does the eye push in, or
the baby's
what happens?
face structure is very soft, and so they drop the baby face down. So this whole thing goes face down like this. So usually there's a tear right here, and we have to sew it up.
On the white part of the eye?
On the white part of the eye.
Wow.
Or between the clear part and the white part. Or common things are scratches, tree scratches, branch scratches in the eye. Little kids are climbing trees, they scratch themselves. People are pruning, they can't see, they stick a rose bush in the eye. Really painful, and what happens is a corneal abrasion. But the bad thing about that, these corneal abrasions, because it's vegetable matter, take a long time to heal, and it could be fungus, and then we have to worry about fungal ulcers. So sometimes corneal ulcer, where they get something in there, they wait a long time, and this vegetable matter, fruit matter goes in here, and it forms an ulcer. It's like taking a petri dish, because the cornea is like a petri dish, and you put bacteria there, it just grows. So parts of your eye becomes white. Wow. So you get a white dot, and then it can be treated with hourly eye drops and antibiotics. If that's not good enough, and it's infected, the infection goes into the anterior chamber part between the roof and the first floor ceiling. Okay. It's filled with pus, and they have to have surgery. And sometimes the pus goes behind the area between the first floor and the ceiling, the anterior chamber, goes to the posterior chamber, which is this part where the retina is, and that's endophthalmitis. And we have to go to the operating room to suck out the pus.
Okay.
So it's like an abscess.
So it requires surgery.
Yeah.
Wow.
Yeah. So, another common one in the winter months is orbital cellulitis in children. People think it's a red eye conjunctivitis. They think it's a red eye doesn't go away, and it comes with fever. It can happen very quickly with children. They have a red eye on like Friday. On Sunday, their eye is swollen shut, cannot open, high fever. That's an emergency. You need ear, nose, and throat surgeon and an ophthalmologist. They clean out the sinuses, and they have to decompress. And sometimes, if they don't decompress that, the little baby will go blind.
Oh no!
So if you have fever in a baby with the eye swollen shut, the red eye, it's an emergency. They need antibiotics.
Oh, okay. So when you go with the patient and they say, Dr. Wu, I see flashes of light, I feel like there's a shade coming down or up, what is the first thing you think about?
For me as a retina surgeon, once you say flash of light, shade, retinal detachment.
Okay.
Immediate. That's like our synonym. We think, like red and blue states, you know how people think red and blue states, national election, we think retinal detachment. Because what happens is, here's the eye. So imagine you're standing in the room and you're the eye again, you're lying on the floor, and where you're standing is the macula. And the room, instead of being filled with air, is filled with a gel called vitreous. So this whole inside is filled with vitreous gel. So depending on your age, let's say you're young, let's say you're 20 to 40, and this vitreous should be solid jello, solid, holding up the retina.
Okay.
So it would be this gel filling this room, holding up all the wallpaper, holding the floor. Now imagine an earthquake. The room moves.
Yeah.
So then what happens, this earthquake, the room moves, the gel is going to move. It's going to rub against the wallpaper. So the wallpaper has all these blood vessels. It's going to rip them apart. And this gel is going to rub against the retina, which is like the film inside the camera. It's going to give you flashes of light because the retina is programmed to see light.
Okay.
So the retina being rubbed against is going to have light flashes. It's going to say something is rubbing against me. I'm programmed to do on, off, respond on light. So you get light flashes. Then when they see this shade coming down, the wallpaper, the retina is falling off. The vitreous pulled it off because this earthquake is happening, right? This earthquake is happening. And this so that you then get this shade because it's no longer attached to its blood supply, the retina. So you lost that part of the vision. That's why you have the shade. You lose vision. So the shade could be coming sideways, up and down, or down below. That tells you what part of the retina is being messed up, being pulled off. The wallpaper is being pulled off.
So is a retinal detachment always considered an emergency, or is there a time frame where it's not considered an eye emergency anymore?
If the macula is on, remember you're standing in the middle of the room where you're standing, X marks the spot, that's the macula. If the macula is on, you have 24 hours to fix it.
What does that mean exactly, macula is on?
That means that the part that gives you the best vision is on, so you have to try to fix the retina as fast as possible to save that vision. But if you've lost all vision, that means the macula is off, so that little part of the area, the room that you're standing is nice and flat, no longer flat. You're standing, that room where you're nice and flat, the linoleum is flat, the carpet is flat, that X, the macula, that you're now as high as the first floor ceiling.
Not good.
No. You are so separated from the blood supply. This is no longer an emergency. But we should do it soon. The sooner the better, but not within 24 hours. You have time.
So what's the outcome of retinal detachment? What is the success rate?
85% do well. However, if you're that 15%, another additional percentage, about half, will do well again if you have a simple retinal detachment, meaning one hole, you do a simple procedure like a scleral buckle or a vitrectomy. But if let's say it's complicated, It's complicated in the sense that your macula, you ignored it for a week, or 2 weeks or a month. You don't even know it's off. You never, because some people don't close one eye and check, and some people don't even notice their vision. They just think, I see. They don't feel any pain. I just see. I'm fine. I can do everything I want to do. So they come to the doctor's office, and the doctor says, oh, you have a retinal detachment. Never noticed it. Some people have come and they never noticed it.
Wow.
They just think, oh, it's been bothering me for 6 months, and I'm just going to come in now.
Yeah.
Those are old retinal detachments.
Are those
hard to fix?
okay?
We can get it anatomically on so it still looks beautiful to us, but they don't see so well. Maybe they see the big E, or maybe they see 20/80.
So the
but
function will no longer be the same as if you would have operated right
Sooner.
away.
Right.
Okay.
And sometimes people got hit in the eye, and all these structures are all messed up. So it's imagining having a major earthquake, hit in the eye, major earthquake, the roof collapses onto the first floor ceiling. You have to re-put the roof back into place. So all the structures are all messed up, and the room that you're standing is kind of collapsed. That's hard to fix.
Oh,
So it takes many things to fix at the one time.
Wow.
The other thing is, people can have had no trauma and get a retinal detachment. Those are people who are extremely nearsighted. They're just at risk.
Okay.
So they have thin retina. So that means the wallpaper that they were born with, the retina that they were born with, was thinner than most people.
Is that because it was stretched because of the length of the eye?
Right,
Or?
because in high myopia, the eye is not nice and round like this. It's long, it's oval. But God gives you only so much retina.
Yeah.
That same amount of retina has to be stretched over a bigger oval. So it's thin. So you have more capability of having abnormalities of your retina and your retina falling off. Now, when I use the analogy, like people have flashes of light and floaters, sometimes, and I said the earthquake, okay, sometimes people can't remember, but 2 months prior to the retinal detachment, they fell snowboarding, they fell skiing, they had a car accident, they hit that side of the head, they hit that side of the shoulder, and then 2 months later they get a retinal detachment. So that earthquake inciting incident doesn't have to be the day before.
Oh, okay.
It could have been 2 months ago, 6 months ago, or they were deciding to suddenly bench press 300 pounds because they were going to redo their life, and suddenly they're lying on the bench, they're bench pressing 300 pounds, they see flashes and floaters, they ignore it for 3 more days, they lose vision in that eye, and they have a retinal detachment. Why does that happen, bench pressing or lifting very heavy objects?
Why is that?
Well, if you imagine, you look at the Olympic sports, you know how those weightlifters in the Olympics, they lift all those weights, and then their neck gets really swollen, and then their face turns really, really red as they're pushing up that 300 pounds or 400 pounds, whatever they're pushing. I can lift like 15 pounds. But what happens is that this eye is not this local thing in your head. It's connected to all these blood vessels. So in your neck, you have the internal carotid, and you have that internal carotid has the ophthalmic artery, and all those blood vessels surround the eye. So if you have this sudden, huge surge of blood pushing upward all through your neck, and you see this strain, your face turns all red, all the blood vessels suddenly go forward.
Okay.
So that's like a little mini earthquake.
Yeah, detaching.
Yeah, like
retina.
putting force on this eye.
Wow.
And the retina, I told you, is only 350 microns thick.
Yeah.
So you have this surge going like onto this thing that's only the diameter of 6 hairs. It's going to feel this sudden push.
Yeah.
And especially if your retina is thin, you never check. Some people never check their retina after LASIK. People who are nearsighted, they see perfectly. They think, my retina.
Okay.
No, they fixed only the front of the eye. You were born with bad retina already.
Yeah,
that's why you needed the LASIK. You need lifelong checking of your retina because your retina is thin. So again, that's another time bomb. People don't realize that. So we see them as emergencies. It keeps all of us busy at 2 o'clock in the morning sometimes.
I bet. So when you have a detached retina and you don't really take care of it post-surgery, can it still fall off?
You can always fall off. This retina is kind of funny that we're so lucky we have it on all the time. It's 350 microns thick, and we fix it. We tell them it takes about 6 weeks for it to really, you know, suck back into place.
Okay.
And some people think, oh, I feel fine, I feel no pain, because the eye has very little pain fibers.
So I feel fine, I'm going to go run a mile.
Yeah, right after surgery. I have people do that. And then they detach their retina.
Oh, wow.
Duh. You know, we tell you not to do this.
So
you
if
know?
you detach from one side, are you prone to detaching your other eye?
Yes, because you're symmetrical. You know, you have 2 ears, 2 eyes, and the way you're born, you're symmetrical. Your hands are symmetrical. So if you have a defect in one eye, you're likely going to get a defect in the other. So people will prophylactically, to prevent, laser the other eye, certain spots that they think that are already weak.
Wow, so interesting and so delicate. People don't really realize how, you know, easily they can, by pulling weeds.
You're hard, especially
jogging.
especially if you're older. If you're no longer 16 or 20 years old, and you decide to go, okay, I'm gonna lift this 50-pound bale of hay because I've always done it. Don't do it.
Yeah. Can you get a retinal detachment from constantly being on the computer monitor, reading, or does that?
What happens with high myopes, you know, people who wear thick glasses, and some of the computer engineers do wear thick glasses, but they look beautiful now because of LASIK, but they think they're cured.
Yeah.
Wrong. Their retina is still abnormal. So what happens is that if you're staring at the computer all the time, these are the muscles, the 4 muscles, superior rectus, inferior rectus, the 2 lateral rectus muscle and medial rectus muscle. So you're staring at the computer. These muscles, where they're on the outside of the eye, is exactly where the retina is, where it starts forming. That's like the edge of the wallpaper on the top of the first floor ceiling. So at the edge of your first floor ceiling, imagine right outside of the house, of your stucco house, there are these pulleys there. So those pulleys, when you stare at the computer all the time, are pulled tight.
Okay.
So there are pulleys outside your house on the first floor at the top edge of the ceiling, pulling, 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 pulling. Can you imagine you pull on that 8 hours a day, all the time, and you're born with weak retina right there? There's going to be change.
Yeah,
you're going to model your eye. Your model is going to change over time. So you're causing structural change. We just can't quantify it.
Okay.
And we can only sort of guess. We just don't think it's good for you to stare nonstop at the computer 8 hours a day. It's like squeezing a tennis ball 8 hours a day.
Yeah.
At the end of the day, you can't open your hand so well. It feels
stuck.
Yeah.
Yeah, wow. So, like you said, both eyes are symmetrical. Are there any tips on not to get detached on the other eye?
See your retina surgeon. You have to see a retina specialist. And what they will do is look very carefully to see where it might have a hole, and they usually will laser it.
Okay, wow. So thank you, Dr. Wu, for letting the studio audience and people everywhere watching our show, what are some retinal surgeries or even eye emergencies in the hospital. If you have any of the following diseases, you know, glaucoma, you see the shade coming down, please don't wait. Please go to the emergency room. Thank you for watching our show.